Dear colleagues, we will speak now about ocular allergy and the pathways from the ophthalmologist to the specialist in allergology. Here are my disclosures. We will speak about the basics mechanism in allergy in the eye, but very shortly we will speak about the usual signs of allergy in the eye, the borderline form of allergy, and when allergy may mimic or worsen dry ocular surface disease, and when it is time to suspect ocular allergy in clinical practice. So what are the basic facts to explain allergy in the eye? This is a scheme from Mr. Leonardi. We know that the first step is the sensitization of the dendritic cells and the T cells, which will educate the B cells. And then there will be an early phase reaction with the secretion of mast cell mediators, chemokines, cytokines, enzymes, neuropeptides, adhesion molecules. These early phase may be followed by a late phase reaction with inflammatory cell migration and activation, the secretion of growth factor, the modification of the epithelial cells and the keratinocytes, and the fibroblast activation. Then this late phase reaction may be followed by a chronic disease with an epitheliotoxic mediator release, an increase in the tear film osmolarity, the secretion of proteases, all of them leading to corneal damage and tissue remodeling. What are the usual signs of allergy in the eyes? The main clinical signs are the papilla, and they are very easy when they exist when you invert the superior eyelid and you look at the conjunctiva on the tarsal part of the eyelid. You can see also some follicles in the lower part of the conjunctival cul-de-sac or around the bulbar conjunctiva. You can see in the severe situation the Trantas dots. These dots are indeed the site where a lot of immune cells are coalescent, and in the most severe situation, you may have corneal shield. This is an ulceration of the epithelium with an ulceration also of the anterior stroma, and in the chronic forms of allergy, you also may have some limbal insufficiency with conjunctivalization of the peripheral cornea. The classification of allergy in the eyes is divided in 4 subtypes: the seasonal or intermittent allergic conjunctivitis and the perennial persistent allergic conjunctivitis, and the 2 more severe forms, which are the Vernal Keratoconjunctivitis and the Atopic Keratoconjunctivitis. The cellular infiltrates is the same for the 2 former forms, with a lot of mast cells, eosinophils, neutrophils, while there are a lot of T cells with the secretion of multiple cytokines in vernal and atopic keratoconjunctivitis. The seasonality is very marked by definition in the seasonal conjunctivitis and can be found also in the vernal conjunctivitis. In atopic keratoconjunctivitis, there may be some seasonality sometimes, but by definition, the perennial is not seasonal because there are signs and symptoms for during the whole year. And the signs are common in all the forms, with itching, burning, watery eyes. But what is very typical of vernal conjunctivitis is the photophobia, very severe in these young patients. This disease can be maybe sight-threatening, while with the atopic keratoconjunctivitis, what is very typical is the severe itching and the stickiness and the redness of the skin all around the eyes. The management of VKC and AKC requires additional therapeutic tools due to the involvement on non-AGE-mediated immune response. Indeed, the two forms, the less severe seasonal and perennial conjunctivitis, are only immunoglobulin E mediated, while the other are non-EGE mediated, and this will explain the need for more complicated treatments like topical cyclosporin, for example, or the requirement to the help of the dermatologist for systemic treatments. So if we come back to the semiology, the seasonal and permanent conjunctivitis are typically seen with these symptoms, with the papillae on the conjunctiva of the upper eyelids, on the tarsal upper eyelid, and the redness of the eye. You can ask for extraocular signs of allergy, like clear runny nose, sneezing, or dermatologic signs of allergy. The Vernal Keratoconjunctivitis is a more severe form. It's a rare disease. The rate is about 10 on 10,000 inhabitants in Western Europe. This affects mostly the young people and male patients. The main signs are papilla plus itching plus conjunctival hyperemia with superficial keratopathy. You can see the giant papilla, very typical of this form when you see a young adult or a child with this form of allergy with the transverse dots. And the complication can be the ulcer shield, the shield ulcer, I'm sorry, the conjunctival fibrosis, as you can see on this picture on the bottom right, or the Limbo cell deficiency, which can be very severe and sight-threatening at the end. This is a complication seen in about 1% of cases. Atopic Keratoconjunctivitis is by definition associated with a personal history of atopy. So it is logical to find it in more than 95% of cases. Most of the times there is a systemic or eyelid eczema or atopic dermatitis. This is also frequent to find some meibomian gland disease with chronic blepharitis. And a lot of patients may have conjunctival fibrosis at the later stages. The usual signs are also the madarosis. This is the lack of eyelashes on the eyelids with a very thick skin around the eyelashes, and the Donny Morgan signs with the double fold on the lower eyelids. And finally, all the signs of eczematous lesions on the skin around the eye, like in this patient. But if you look behind the ears, you can find these very typical lesions. And of course, don't forget the risk of keratoconus in this patient and the risk of also cataract in this patient. There are some borderline forms of allergy. The one typical is the tropical endemic Limbo conjunctivitis. This is a severe form of VKC that is found in Middle Africa. This is probably due to concomitant environment factors like the sun, but there are now a lot of evidence that the microbiome of the eyelid is also involved in that very severe cases, in these very severe cases of VKC with sight-threatening complications in these young people. The second form is the giant papillary conjunctivitis. This is a reaction to a foreign body. Most of the time, these are sutures or contact lenses or ocular prostheses. The signs are very close to those of VKC, with giant papillae, pruritus, mucus discharge. They are seen in young people. Atopy is a risk factor. Here is an example of a patient while wearing contact lenses, and there was recovery partly, but recovery 2 months after stopping the contact lenses. And 12 months later, there were almost no signs for this patient. Another borderline form is the contact blepharitis. We will discuss it with Jérémy GOTTLIEB in the following talk. This is a reaction to a toxic, mainly from eye drops in the case of ophthalmology, of course, or cosmetics, and here are two very typical examples. This is very different from the usual allergy, as I have showed some pictures before. There are some conditions where an allergy may mimic or worsen other ocular surface disease. The first one is dry eye disease. The typical history is a history of a dry eye disease with burning, stinging. However, this history is not continuous during the whole year. There are some periods of exacerbation of the ocular symptoms with or without episodes of rhinorrhea or sneezes or pruritus. And there is one cases patient with a dry eye disease, symptoms of dry eye disease, but the breakup time is 15 seconds. This is a lot. Schirmer 1 is not so bad at 9 millimeters at 5 minutes. There is no history of preserved eye drops. You can see the signs of toxic tears with the epitheliopathy, mostly in the inferior part of the cornea. There is no MGD, but there is an exacerbation during the spring. And if you invert the eyelids, the upper eyelid, you will see the signs of allergy. And indeed, treatment of allergy together with the treatment of dry disease improved a lot that patient. Another case where the patient was investigated with the multipurpose device, such as Lacrydial by Cantel, and the patient had symptoms of dry eye disease with an OSDI at 45, which is a severe level of symptoms, but non-invasive breakup time was quite good. Tear meniscus 8 was high. So I'm sorry for the typo error. There was no preserved eye drops either in the patient. The dry eye disease was, the so-called dry eye disease was continuous but irregular. And indeed, there were multiple signs of allergy. And we treated the patient with anti-allergic eye drops, and he was most improved. There is another disease where allergy may mimic or worsen the ocular disease. This is the Hepatic Keratitis. Data were first confusing about the relationship between herpes keratitis and allergy, but now it is clear that there is not a significant increase in the frequency of keratitis in atopic patients, but in these atopic patients, there are more frequently very severe forms of herpes simplex keratitis, and there is another percentage of atopic patients among the primary attack of HSV keratitis and among the recurrences. So atopy is a risk factor for severe herpes simplex disease, and here are some pictures from young people with the typical keratitis, as you see on these pictures. And finally, when we looked more closely at the eyes, we found some signs of allergy with lambitis, with some infiltration of the limbus, as you can see there or there. And then the patient was treated together for the herpes and for the allergy, and the condition improved. So in conclusion, when should we ask the help of the allergologist, and when to suspect an ocular allergy? Of course, we should ask the help of an allergologist in case of very severe form of ocular allergy. Any suspicion of vernal keratoconjunctivitis or atopic conjunctivitis needs the advice of a dermatologist. He will go further in seeking for associated signs and in adapting cutaneous and systemic treatments. And we should also suspect an ocular allergy in case of an apparently usual form of allergy, but with a recent loss of control, and in case of atypical dry eye disease or in case of atypical herpes simplex disease, especially those that do not respond to conventional management. And here is the last example of a young patient who came to our department for an atopic keratoconjunctivitis, and 6 months later, after a very important collaboration with my colleague, the condition of the patient had improved a lot. He was smiling, he was able to going back to his work, and he was a very happy patient, as us, we were very happy. So thanks to my dermatologist as a colleague, and I will give him the talk now. Please, Jérémy, can you give your talk about the way to manage atopic dermatitis?
Thanks, Marc, for these kind words, and thank you again for the invitation to talk about our collaboration in Bicêtre Hospital near Paris. So this is my disclosures for the last 5 years. So what are we talking about when we talk about chronic allergies? There are 3 situations. The first one is atopic dermatitis with eyelid involvement. Second one would be contact dermatitis of the eyelids. And the most challenging one maybe is atopic dermatitis with contact dermatitis, and that could be the most frequent or the most the less regarded diagnosis, and that's what I'm gonna talk about. So this is the only complicated slide of my slide desk, but I will make it fast. Just to remind you that when we talk about atopic skin, it's a mixture of activation of the innate defense system with keratinocytes and TSLP, and the immune system, the activated immune system with Th2 lymphocytes. And that are the targets that we will use for the treatments. So how can we help as dermatologists, or can we be of help to ophthalmologists? First, we can help with diagnosis of atopic dermatitis or contact dermatitis, and then we can help to treat from a dermatologic point of view. So that's a picture with dermatitis of the eyelid, and I ask you, do you think it's contact dermatitis or do you think it's atopic dermatitis? How can we go forward to the diagnosis? First, some keys, very simple keys. What is atopic dermatitis? We have a definition that lasts since 1994, and it's unchanged since. You need two conditions with history of pruritic skin condition. That's the main and the most important thing. An onset of the disease under the age of 2. A visible flexural dermatitis, a dermatitis of the folds, or a history of flexural involvement, a history of dry skin, and a personal history of asthma. And I extend it to a personal history of rhinoconjunctivitis or food allergy. And you can also apply these definitions to the patient's first-degree relatives, the parents, the brothers, sisters, or the children. So the second key for a diagnosis of atopic dermatitis is the definition of atopic march. This is very march-like. You begin at the age of 3 or 4 months of age with food allergy and dermatitis, and they don't really have a link. There is a common mistake to mix milk allergy and dermatitis, but it's not the same condition, even if it's linked. And then a little bit later, at the age of 1 or 2, you have asthma that arises, and then rhinitis and conjunctivitis. But if you go later, that's at the end of childhood. But if you go later, dermatitis can go again like this. So at the age of 20, 25, you may have a dermatitis again. So one very, very important thing is that if your patient is atopic, the eyelid dermatitis can still be a contact allergy. It's not because you have atopy in the family or in personal history of atopy that your eyelid is only atopic dermatitis. So the only thing to make a difference is to test, because if you perform a skin biopsy, you will have very much difficulty to say if it's contact or atopic dermatitis. So you need testing, just like for COVID-19. So you have two solutions. One is patch test, which requires an allergologist or a dermatologist. So that's not very easy, and that takes time. And you have the possibility of ROAT, repeat open application test, which is very simple because it requires nothing but a suspected allergen. So it needs a good questioning of your patient and to find out which are the suspected allergens. And then you apply the allergen twice daily on the unaffected skin, often on the forearm, and you see what happens. So here are some pictures. This is patch testing. You have tests that are already defined. For example, the common European standard battery, and you put it in the back of the patient, and you come back 2 days or 3 days later, and you see what reacts or not. This is the first picture I show you, and I asked you, was it contact or atopic dermatitis? It was contact dermatitis, because here you have the solution with the forearm of the patient after timolol RO80. So in fact, you put timolol on the forearm of the patient twice daily, and here what happens? There is dermatitis. So in fact, the patient is allergic to timolol eye drops. So it's very easy. You stop timolol eye drops and you find another treatment for your hypertensive ocular session. Here is another picture, and I thanks Dr. Crépy for the picture. Here you have contact dermatitis due to paraphenyldiamine, PPD, which is very frequent in beautician or haircut maker, because PPD is often used in colors for hair. So here you see a dermatitis, which is very close to the eyelids, eyelashes. Here is a picture of chronic contact dermatitis due to epoxy resin. It was an artificial flower maker. And you see that sometimes the diagnosis is more complicated. And you see some scales here, scaly eruption. So you might have mistaken with a seborrheic dermatitis. Here is another patient. You see dermatitis of the eyelid and on the cheek, might have also a rosacea also. And you do the patch testing and you see a lot of positive tests, including fragrance mix and nickel. And here there were two culprits, an essential oil diffuser, which is the fragrance positivity, and nickel, because the patient had a paperclip biting tick. She had a paperclip always in her mouth, and she was allergic to the nickel and to the essential oil diffuser. So if you ask her to stop biting the paperclip and to stop essential oil, then she's better. Here is a table where you see that for a contact allergy involving the head, the nickel and the fragrance mix are the most frequent culprits. So that means you have to search for nickel, which is sometimes in the smartphones, and to search for fragrance, which are a lot of cosmetics. Here is a patient, younger patient, that is known for AD, for atopic dermatitis, but she has a worsening of AD for the last year. So you might say it's just a worsening natural history of AD, but you need testing. And if you do the testing, you see that she's positive for balsam of Peru, which is something that we can find in a lot of creams and cosmetics. And she's positive also to fragrance. And when you do RO80, you see that she's in fact allergic to her toothpaste. So she has to change her toothpaste and her face will be better. Here is another patient with a worsening of a known atopic dermatitis for the last year involving the head. So you might say it's only the atopic dermatitis, but you have to test. And if you do the test, you find nothing. So this patient had an eyelid atopic dermatitis only, and there were no contact dermatitis associated. So how can we help the ophthalmologist to treat atopic or contact dermatitis? If it's contact allergy and you need testing to tell it, please then avoid the contact, but it's not always easy. For example, if you're a beautician or a haircut maker, it's difficult to avoid PPD. So that's sometimes we are confronted to difficulties like that. But if it's atopic dermatitis, then you have this table, which is unreadable. So that's why I've put it in a few slides next. So the first treatment, the baseline treatment, it's for everyone. It's educational programs and emollient moisturizing creams. And again, avoidance of relevant allergens if there are allergy tests proving that there is a contact allergy. Then you have the possibility in mild dermatitis to use topical glucocorticosteroids that we can use on the eyelids, but you know that we want to spare steroids on the eyelids because we fear for the adverse event of steroids on the face. So we can also use topical calcineurin inhibitors, and we in France use tacrolimus ointment, which can be applied on the eyelids with no problems. But you also have pimecrolimus cream, for example, in Germany. We don't have it in France. In the US, you also have topical crisaborole, which is a PDE4 topical inhibitor, but we don't have it in France. And the systemic PDE4 inhibitor doesn't work. Then, if your dermatitis is worse, it's moderate, you can also ask the dermatologist to perform UV therapy. But the COVID-19 crisis made it difficult to access to UV therapy because most of private practice closed their UV cabins. Also, it's a suspensive treatment, and there is a potential neoplastic risk with non-melanoma skin cancer. So I don't usually perform UV therapy, particularly in patients that only have had atopic dermatitis of the head. Then, if it's more severe, involving more of the skin, we have other treatment that we can do and that you as ophthalmologists can do. And for example, cyclosporin A, which is a very good weapon, highly and rapidly efficient, but with a lot of adverse events. So it's becoming a more and more difficult treatment nowadays because of the renal dysfunction, the risk of acute increases of blood pressure with headaches, and in women, the problem of hair growth. The systemic glucosteroids are here in the guidelines. It's a European guidelines. We in France don't use it, and it should probably be the last weapon used in dermatitis because of the risk of rebound after the end of the steroids, when you're tapering off steroids. And then you are in chronic difficulties because the patient is happy with steroids and doesn't want to stop it. So you have other problems with the bones and blood pressure and diabetes and all that stuff. So we now have a very powerful tool, which is dupilumab, which is an inhibitor of IL-4 and IL-13, which are two key proteins in the Th2 differentiation. But there is a risk of paradoxical conjunctivitis, and that's where we need to collaborate with the ophthalmologist, with you, Marc, to say if we can prescribe dupilumab in patients with with atopic dermatitis of the eyelids and with dry eyes, of course. And here you see the last alitretinoin treatment, which is EMA label for chronic and dermatitis, not for the face, but as all other retinoic acid treatments like isotretinoin in acne, there is a risk of increased eye dryness. So I would not use alitretinoin in a patient with dry eye, of course. So that's where ophthalmologists can help us, dermatologists, because there will be likely be an increase of paradoxical conjunctivitis in the next months and years due to all these Th2 inhibitors biotherapies. And you will see that in our pipelines coming next for atopic dermatitis, there are two other IL-13 inhibitors, which are tralokinumab, which is now labeled in France, and lebrikizumab, that are very similar to dupilumab, maybe less conjunctivitis, but still there will still be some conjunctivitis with these treatments. There will also be the IL-31 inhibitors, nemolizumab, which is very interesting because IL-31 is the itch cytokines. So we can stop itch with blocking IL-31. And there are several others treatments that are tested, but you see phase 2, it's not as advanced as IL-4 and IL-13 blockers. And we have also JAK inhibitors, oral JAK inhibitors that are now labeled, which are upadacitinib and baricitinib. So now what we are waiting for are topical JAK inhibitors, because it could be a good treatment for isolated refractory plaques, and for example, for atopic dermatitis and contact dermatitis maybe of the eyelids. Thank you for the intention, and maybe you have some questions for me, Marc, or the audience.
Yes, of course, I have some questions for you, Jérémy, and we have to keep it time, so I will shorten the questions I had. The most important were, how much is it frequent to have atopic patients who require this systemic treatments that may have some side effects and maybe a little bit costly? And what is the global frequency of paradoxical conjunctivitis following dupilumab? And is it a reason for withdrawing the therapy, or is it spontaneously vanishing with time? What is your experience in that?
I will try to make it short. So for your first question, atopic dermatitis is very frequent. It's more, it's like one child up on to 5, and maybe now one up to 4, a child in childhood. But then we frequently see what we call a honeymoon during adolescence, teenager. And sometimes it comes back after the age of 20. So when it comes back after the age of 20, it's more rare, but it's oftenly more severe. So in adult patients with atopic dermatitis, we are frequently in need for these systemic treatments. And now the choice between dupilumab, IL-13 inhibitors, or JAK inhibitors will be partly with the risk of paradoxical conjunctivitis, meaning that if the patient comes with already a dryness of the eye and eye problems, we might go preferably to the JAK inhibitors to prevent us from this paradoxical conjunctivitis. But it's not that frequent, and that will be the answer to the second question. It's approximately 1 patient out of 10 that makes a paradoxical conjunctivitis with dupilumab, maybe 5 out of 100, so half less with IL-13 inhibitors, but we are lacking some information for now. And among these patients, maybe 1 upon 10 will need to stop. That means less than 1 patient out of 100 starting with this kind of systemic treatment will have to stop the treatment, the biotherapy, because of this paradoxical conjunctivitis. So that's where we need your help to manage patients with conjunctivitis in order to continue the biotherapy.
Thank you, Jérémy, for this answer. I think it's time now to close, unfortunately, this very interesting session. I hope you have enjoyed all these talks by brilliant experts. I thank the EuDES, European Dry Eye Society, for the hospitality. And again, I thank warmly Cantel Medical France for the support in that educational program. See you soon on the EuDES website.